Hi everyone, my name is Ashley Johnson, and today I'll be talking to you guys about abnormal uterine bleeding. Abnormal uterine bleeding used to be called dysfunctional uterine bleeding and was recently changed to abnormal uterine bleeding, or AUB. AUB is described as irregular menstrual bleeding that's usually heavy, prolonged, or frequent, and it's a diagnosis of exclusion after the establishment of normal anatomy in the absence of other medical illnesses in pregnancy. AUB is commonly associated with anovulation and most commonly affects adolescents and perimenopausal women. So the incidence of AUB is 5% of reproductive age women will see a doctor for AUB in any given year. And also 10 to 30% of reproductive age women have abnormal uterine bleeding. And anovulation accounts for 90%. So with anovulation, you have a loss of cyclic endometrial stimulation, you have elevated estrogen levels that stimulate endometrial growth, there's no organized progesterone withdrawal bleeding, and so the endometrium eventually outgrows blood supply, breaks down, and then sloughs off from the uterus. So of these women that have AUB, 6 to 10% will also have polycystic ovarian syndrome. So as mentioned earlier, anovulation accounts for 90% of adolescents and perimenopausal women. So perimenopausal women is also termed menopausal transition, and that begins with the onset of cycle irregularity, and it ends at 1 year from the last menstruation. Once there's been an absence of menstruation for 1 year, you go ahead and classify them as menopausal women. So to describe abnormal uterine bleeding and the causes of it, there's a little mnemonic called Palm-Cohen. And Palm describes the structural causes of AUB, and Cohen describes the non-structural causes. Palm, P-A-L-M, is polyp, adenomyosis, lyoma, malignancy, and hyperplasia. And Cohen, C-O-E-I-N, is coagulopathy, ovulatory disorders, endometrial, iatrogenic, and not yet classified. So for these patients in a menopausal transition or perimenopausal, bleeding at this time is also likely anovulatory. So what you're going to do for these patients is put them on a progestin-only oral therapy. There's no contraceptive coverage, and so they're going to be on something like medroxyprogesterone acetate, 10 milligrams daily for 14 days each month. So when you're working up these patients, it's really important that you are getting a quality menstrual history as well as a quality gynecological history. So as far as their menstrual history is concerned, make sure that you're asking them questions about their onset, severity of bleeding, how often they're using and changing tampons, which type of tampons, are they passing clots and how often, and the timing of their bleeding. As far as their gynecological history, you want to assess their gravity, parity, STI history, previous PAP results, and ask about medications such as aspirin, anticoagulants, and any hormonal therapy they may be on. So during your physical exam, you're going to want to evaluate them for obesity, anemia, and thyroid conditions. You're going to want to get a CBC in a urine to rule out a pregnancy, and if anovulation is suspected, go ahead and get a TSH and a prolactin level. During your pelvic exam, you're assessing for any uterine irregularities, potential foreign bodies, and make sure that you're doing a pap smear and a STI test as well. So treatment for AUB is most commonly going to be NSAIDs for general measures. This is going to decrease the amount of blood loss and pain that your patient is experiencing. So if there's a non-acute, if this case of AUB is non-acute, non-ovulatory, you're going to put them on an IUD such as Mirena. It's the most effective form of progesterone delivery and is not inferior to surgical management. So if it is an acute, non-emergent, non-ovulatory bleeding, you're going to put them on a combination oral contraceptive pill. And you'll want to give them estrogen as a taper. So for example, you'll give them 4 pills per day, 4 days, 3 pills per day for 3 days, and so on and so forth. So when you're educating these patients, make sure that they understand that most anovulatory cycles can be treated with medical therapy and don't require surgical intervention. If you guys have any questions, please feel free to email me, and I'll be glad to get back with you whenever. All right, hope y'all have a great night. Bye.